aware by now because we've had a number of graduating residents present grand rounds recently. But this is in fulfillment of their requirement for scholarly activity, which is part of the ACGB requirements for pediatrics. And so today, Dr. Mamilly is going to present type 2 diabetes, which is now, I think that, which he'll discuss, but is definitely now a pediatric problem.
Thank you, Dr. Cooper. So today we'll have a sweet talk about diabetes. The objectives in this study is to identify type 2 diabetes as a pediatric problem now, since it has increasing prevalence as a result of the childhood obesity. Perform and interrupt the appropriate diagnostic studies for diagnosis of impaired glucose tolerance and type 2 diabetes, recognize management options, comorbidities, and their indication for treatment. So we'll start with some facts about type 2. It's formally known as adult onset diabetes, which usually diagnosed in adults aged 40 years or older. It's now the worry of physicians taking care of children and adolescents because it's been reported to have increased frequency among children in the United States and around the world. So in the past 3 decades, there have been reported of diabetes type 2 in teens or even children in their first decade of life. That poses a challenge to many pediatricians who are now dealing with an adult disease, since most of the diabetes management education tools are directed primarily to families of children with type 1 diabetes. And in addition to that, most of the medication used for type 2 diabetes have been tested for safety and efficacy in people 18 years and older. So it's a complex metabolic disorder of heterogeneous etiology with the social, behavioral, and environmental risk factors, unmasking the effect of genetic susceptibility. The problem starts with insulin resistance that the body in the beginning compensates for by increased insulin secretions to maintain normal blood glucose, and that's set up for impaired glucose intolerance or prediabetes that could be presented as impaired fasting glucose as well. So the progression of insulin resistance will lead to pancreatic beta cell failure to compensate for this resistance, and that leads to high blood glucose and frank symptoms of diabetes. So it's a combination between both insulin resistance and insulin deficiency. These numbers are from the National Diabetes Statistics 2011, published in the United States Department of Health and Human Services. They report about 215,000 people younger than 20 years have diabetes, both type 1 and type 2, which represent about 1 in 400. There's about 15,600 child newly diagnosed with type 1 diabetes annually, and about 3,600 newly diagnosed with type 2 annually. And type 2 diabetes represent about 8 to 46% of all new cases of diabetes referred to pediatric centers. And this wide range is because it has high difference between different age group in pediatric population and between different ethnic groups as well. So as we see in here, in patients less than 10 years of age, the number for type 1 diabetes is 19.7 per 100,000 per year, and 0.4 per 100,000 per year for type 2 diabetes. For children more than 10 years of age, the number is almost the same for type 1 diabetes, but there is a huge difference in type 2 from 0.4 to 8.5 per 100,000 per year. As I said, it's more observed among children between 15 to 19 years of age, and the incidence varies greatly by ethnic groups. It's highest among Native Americans, around 50 per 100,000 per year, followed by African Americans, a little bit more than 20 per 100,000 per year, then Asian or Pacific Islander, a little bit less than 20 per 100,000 per year, followed by Hispanic, and the lowest among non-Hispanic whites, which represent 5.6 per 100,000 per year. This chart showed newly diagnosed cases of diabetes in both type 1 and type 2 groups before 10 years of age and after 10 years of age. Yellow color is for type 1 and orange is for type 2. As we see, less than 10 years of age, most of the cases are in non-Hispanic whites, and it's mostly type 1 diabetes, while in older children, it's more among Native American, and it's more type 2 cases. And we'll see overall increased incidence of type 2 diabetes. So as I said, it's not a problem limited to North America. It's reported all over the world. So in Taiwan, it's represent 54.2% of newly diagnosed diabetes cases in school-age children, while in Japan, it's 80% of all new cases of diabetes in children, and it represents 34.9 per 100,000 per year in coitus children, which is in Middle East. And it's the least in Europe. The number is 1 to 2% of young onset diabetes cases. However, the magnitude of type 2 diabetes is probably underestimated because of undiagnosed cases or misdiagnosed cases with type 1. And this graph shows the trend of diabetes over the past 50 years. As appears in here, the diagnosis has increased over the past 50 years due to multiple factors, but mainly obesity. And there's a significant increase in mid-90s. It's most probably due to increased use of technology in daily basis and increased consumption of fast foods. So the incidence of type 2 diabetes is directly correlated with the incidence of obesity. The 2011-2012 data showed 8.4 of children 2 to 5 years old were obese, and 17.7 of children between 6 to 11 years, 20.5% on children between 12 to 19 years old were obese. And they have almost the same ethnic group distribution that's seen in type 2 diabetes, higher among Hispanic, followed by non-Hispanic black and non-Hispanic white youth. All right. And this slide is going to show, let me just play it. I think I have to go out like this. Increased incidence of obesity and diabetes over the past 15 years. Obesity in the left, diabetes on the right, and the darker the color, the higher the prevalence of the disease. So obesity is everywhere now. So now talk about pathophysiology. In normal individuals, glucose concentration remain within narrow range in fasting and fit state. This tight glucose regulation maintained by a delicate balance between insulin secretion and insulin sensitivity, which best described by hyperbolic function, which indicates that the product of insulin sensitivity and insulin secretion is constant at given glucose tolerance. Go to this slide. So a normal person, when insulin sensitivity decreased, compensatory increase in insulin production will happen to maintain normal glycemic status. failure of this compensatory will lead to impaired glucose tolerance and diabetes. So the type 2 diabetes curve will be even lower than the impaired glucose tolerance will go this way. So the main two components are insulin resistance and insulin production. So what causes insulin resistance? As we said, obesity is the major factor. The mechanism of insulin resistance caused by obesity is related to changes in fatty acid metabolism that interfere with normal glucose metabolism and is related to factors produced within fatty cells that antagonize insulin action. Most notable of these factors are hormones, adiponectin, leptin, and resistin, which are produced by fatty cells and are likely major link between obesity and diabetes. Some studies showed decreased insulin sensitivity in obese adolescents with high visceral fat, and growth hormone is considered as a candidate for causing insulin resistance during puberty. And the other risk factor is polycystic ovarian syndrome in girls that will cause decreased insulin sensitivity. And of course, we have the role of genetic susceptibility as well. Now, the ability, we'll talk about the other component, production of insulin. The ability of beta cells to secrete sufficient insulin to respond to the insulin resistance depends on multiple factors, include beta cell mass and secretory capacity, which influenced by genetic and environmental factors. The persistent insulin resistance, in addition to lipotoxicity, will lead to progressive loss in beta cell function. And another factor is decreased beta cell mass by ectopic fat disposition in the liver. Several studies have suggested that beta cell dysfunction depends also on pre-existing and perhaps genetically determined risk, which is crucial for beta cell dysfunction to occur. And here is like to summarize the pathophysiology, we have genetic environmental factors as well as other risk factors will cause insulin resistance that will give us hyperinsulinemia at the beginning with normal glucose tolerance. The body will compensate by producing more insulin. If the problem persists, the patient will have symptoms with postprandial hypoglycemia, and persistence of the problem will lead to decreased beta cell function. The body will fail to produce more insulin to compensate for this resistance. This decrease in beta cell function have another genetic environmental factors as well as glucotoxicity and lipotoxicity, and that will lead to type 2 diabetes symptoms. Now, what are the risk factors for diabetes? We'll talk about every single factor of these. We'll start with genetics. There's a strong family history present in most pediatric patients with type 2 diabetes, regardless of their ethnic background. And the genetic component of type 2 diabetes is evidenced by strong hereditability of the disease, although few genes have been identified so far. The lifetime risk of developing type 2 diabetes in first-degree relatives of persons who have type 2 diabetes is 40%. There's a study on studies in adult twins demonstrate a 50 to 76% concordance rate of type 2 diabetes in monozygotic twins and 37% in dizygotic twins. The hereditability of type 2 is 26%, and the hereditability of abnormal glucose intolerance is 61%. There was another study showed that there is 25% lower insulin sensitivity in prepubertal healthy African American children with family history of type 2 diabetes compared to their compared to their peers without family history. So they have family history, they have 25% lower insulin sensitivity. And same results were obtained in white children as well. So the other risk factors of environment, which include behavior and lifestyle that leads to obesity. So increased prevalence of type 2, as we said, is linked to epidemic of obesity. The increased prevalence of obesity over a relatively short period of time has been linked to environmental factors, sedentary lifestyle, rather than change in genetic pool. Lower adiponectin, which is a protective cytokine, is correlated with insulin resistance, beta cell function, and increased abdominal adiposity. So recent study showed youth without diabetes will, that have obesity will have 50% lower adiponectin than normal children. And children with type 2 diabetes will have furthermore, will have 50% lower adiponectin than obese children without diabetes. Abdominal fat deposition is considered a risk factor for insulin resistance independently from total body adiposity and ethnicity. Now, ethnicity, as we said, is type 2 diabetes is more has more incidence and prevalence among minority ethnic population. A study showed that despite 30% of lower visceral adiposity in African American adolescents, insulin sensitivity were not better than their white peers. And the level of adiponectin is lower in African American compared to the white healthy children, despite of similar body composition. Puberty, the mean age of diagnosis is 13.5 years, which is around the time of puberty. It's associated with physiologic transient insulin resistance. So measurement of in vivo insulin sensitivity demonstrate that insulin sensitivity is on average 30% lower in adolescents between 2 and 4 of puberty compared to prepubertal children and even adults. And it's most likely due to transient increase in growth hormone secretion during puberty, but not steroids. Polycystic ovarian syndrome affects 5 to 10% of women of productive age. Main symptoms: hypergonadism, amenorrhea, and oligoamenorrhea. Insulin resistance and hyperinsulinemia are major components. 30 to 40% of women with PCOS have impaired glucose tolerance, while 7.5 or almost 10% will have type 2 diabetes in their 4th decades. Now, acanthosis nigricans. This is a picture in a white adolescent with acanthosis. It's a diffuse hyperplasia with spinous layer of the skin, manifest as hyperkeratotic darkening of the skin. That's another picture with in 15 years old African American male with obesity, severe acanthosis. We see your skin tags. So acanthosis associated with obesity, hyperinsulinemia, and insulin resistance. It presents in 90% of children who have type 2 diabetes. The prevalence is 25-fold higher in African American children compared to the other population, and prevalence is 6 times higher in African Americans with prevalence of type 2 is 6 times higher in African American children with acanthosis. Prevalence of impaired glucose tolerance is 24% in African American children with acanthosis. But adiposity is still better clinical predictor of insulin tolerance. So obese children without acanthosis should not be presumed to have normal insulin sensitivity. Intrauterine environment, which include exposure to gestational diabetes and intrauterine growth retardation. Offspring to the mothers with diabetes during pregnancy have higher frequency of childhood obesity and early onset diabetes. Prevalence of impaired glucose tolerance in offspring of mothers with diabetes is 1.2% at less than 5 years of age, and 19.3 at 10 years, around 10 years of age. And some studies suggested that the major defect is decreased insulin sensitivity in children born small to gestational age, and others suggest that the problem is insulin secretion. but obesity is still a more powerful determinant of insulin resistance than size at birth. Now talk about screening. ADA recommend to screen children who are overweight, which defined as BMI more than 85th percentile for age and sex weight, for age and sex, and more than 85th percentile for weight for height. So overweight children or anyone who have two of the following risk factor: have a family history of type 2 diabetes in the first or a second degree relatives, belong to certain race or certain ethnic groups like Native Americans, African Americans, Hispanic, Asians, or Pacific Islander, have signs of insulin resistance or conditions associated with insulin resistance like acanthosis, polycystic ovarian syndrome, dyslipidemia, or hypertension. So when to screen, screening should be done every 2 years, starting at age of 10 or at the onset of puberty if it occurs earlier. And ADA recommend using fasting plasma glucose as the screening tool because of the lower cost and greater convenience. Now, the diagnosis will start with the pre-diabetes, which is fasting blood glucose between 100 to 125 milligram per deciliter, or 2-hour oral glucose tolerance test between 126 and 200, or hemoglobin A1C of between 5.7 to 6.4%. And it's important to mention that the deterioration in beta cell function is more accelerated in children with type 2 diabetes than with adults. And there was a study reported 15% more acceleration per year in children. Now, the typical picture of the child with type 2 diabetes will be, the child will be overweight or obese, as we said, BMI from 85th to 94th percentile, has a strong family history of type 2 diabetes, has substantial residual insulin secretory capacity at diagnosis, which is reflected by normal or elevated insulin and C-peptide, has subtle onset, but may represent as a DKA or non-ketotic hyperglycemic coma. Demonstrate insulin resistance, include the clinical evidence of PCOS or acanthosis. There is lack evidence of diabetic autoimmunity, which means negative for autoantibodies typically associated with type 1 diabetes. And these patients are more likely to have hypertension and dyslipidemia than the patient with type 1 diabetes. Now, for diagnosis of type 2 diabetes, fasting glucose will be equal or more than 126, 2 hours oral glucose tolerance test more than 200, and random blood glucose more than 200 with symptoms of hyperglycemia, which is polyuria, polydipsia, hyperphagia. Hemoglobin A1C more than or equal to 6.5%. Now, the management, the most important thing is to recognize that the care of the child with type 2 diabetes should be shared among physician, diabetic nurse educator, nutritionist, and behavioral specialist, along with involving the family members to reach therapeutic goals. So the goals of treatment is to reserve acute metabolic abnormalities, achieve and maintain near normal glycemic states, eliminate symptoms of hyperglycemia, improve insulin sensitivity and secretion, and achieve healthy body weight, and to screen and treat for comorbidities and prevent complications. So the main step in treatment is the first step in treatment will be lifestyle modification. That include 3 essential components: diet, exercise, and behavioral therapy. Lifestyle is successful when multidisciplinary approach is used and the entire family is involved. The patient should be counseled at the time of the diagnosis. Now, according to the Academy of Nutrition and dietetics guidelines, the diet should be between 900 to 1200 calories per day in children between 6 to 12 years of age. And that is associated with both short and long-term improvement if it's incorporated with lifestyle changes. And this calories should be not less than 1200 for patients 13 to 18 years of age. There is no study for single best meal plan for patients with diabetes, but regardless of the meal plan, the patient should be, or the nutrition education should be started at the time of diagnosis. And this education should be encourage the patient to follow healthy eating pattern, such as consuming 3 meals with planned snack per day, not eating while watching television or using computers, using smaller platters to make proportions appear larger, and leaving small amounts of food on the plate, choosing calorie-free beverage except milk, limiting juice to 1 cup per day, which is 4 ounces size cup, increase consuming of fruit and vegetables, limiting intake of high fat food and limiting frequency inside of the snack, reduce calories consumed in fast food meals. It's recommended for all patients with type 2 diabetes to engage in moderate to vigorous exercise at least for 60 minutes, which will play a role in improving insulin sensitivity, increase uptake at the level of the muscles, and decrease need of insulin therapy. Adherence may be improved if the clinician provides a written prescription to the patient to engage in physical activity, including a dose, describing ideal duration, intensity, and frequency. And it's important to mention that recommended 60 minutes of exercise don't have to be accomplished in one session. It can be divided through several shorter periods of time, like 10 to 15 minutes. Limit non-educational screen time to less than 2 hours per day, and discontinue the presence of video screens and television sets in children's bedrooms. Patients should be encouraged to identify a variety of forms of activities that can be performed both easily and frequently. In addition to that, providers should pay attention to potential need to adjust medication dosage, especially if the patient is on insulin as well. So unfortunately, efforts of lifestyle changes often fail for a variety of reasons, including high rates of loss of follow-up, a high rate of depression in teenagers, which affects adherence, and peer pressure to participate in activities that often involve unhealthy eating or drinking. Fewer than 10% of pediatric type 2 diabetes patients will obtain their blood glucose goal through lifestyle intervention alone. So that means patients should have some type of medicine in addition to the lifestyle. As we said, the type 2 diabetes can present multiple forms. The most important is can present as a DKA in 5 to 25% of cases. And in this case, the patient should be treated with insulin and fluid with electrolytes. So insulin is a key component in treatment of type 2 diabetes. So all children with symptoms of hyperglycemia, which is polydipsia, polyuria, polyphagia, who are diagnosed with type 2 diabetes, should be tested, evaluated for ketosis, and ketoacidosis is positive. And even if their phenotype suggests they have type 2, like if they are obese or having acanthosis or PCOS, they still have to be evaluated for ketoacidosis. Adolescents and children with type 2 diabetes with poor glycemic control, which is blood glucose more than or equal to 250, or hemoglobin A1C more than 9, and they don't have ketosis, they will also benefit from initiation insulin treatment, at least on a short-time basis. That will allow quicker restoration of glycemic control and allow beta cell to rest and recover. And when it's difficult to distinguish between type 1 and type 2 disease, like if we have an obese child presenting with ketosis, these patients are best managed initially by insulin therapy, while appropriate test is performed to differentiate between type 1 and type 2. And after that, they can be weaned gradually from insulin therapy and managed with metformin and lifestyle. So advantages of using insulin in type 2 diabetes is to achieve metabolic control, that the metabolic control will be achieved more rapidly compared to metformin therapy. And insulin offers benefit of improving glycemic controls while preserving beta cell function or even reversing beta cell damage, which is known as pancreatic rest. And initial use of insulin therapy may convey the patient of a sense of seriousness of the disease. So because when they have like an injection every day, they will be more serious about the disease. Now, metformin is the only medication that is FDA approved to be used in pediatric patients. Unfortunately, there's limited data for the use of other currently available hypoglycemic agents that we use in adults, except for the insulin. Because of low success rate in diet and exercise alone, metformin should be started as a first-line therapy with or without insulin, along with the lifestyle changes, unless the insulin is needed to reverse glucotoxicity. So it binds to insulin receptors in liver, muscles, and fat tissue, and the mechanism of action has two folds. It primarily affects effects of metformin is to reduce hepatic glucose production, and metformin also increase glucose uptake of peripheral tissue in the muscles and fat, with net effect of improving insulin sensitivity and reducing both pre- and postprandial blood glucose level. So the advantages of metformin, other than it's the only medication that we can use, it has potential weight loss or weight neutrality. Because of low risk of hypoglycemia, we need less finger stick to measure the blood glucose compared to insulin and other agents like sulfonylurea. It improves insulin sensitivity and may normalize menstrual cycle in females with PCOS. But metformin will improve fertility as well, so contraception is indicated for sexually active patients who want to avoid pregnancy. And it's a pill, so it's taking the pill does not have the discomfort associated with insulin injection. And it needs less instruction time, making it easier for the pediatrician to prescribe. And in addition to that, adolescent patients don't always accept injections, so oral medication might enhance adherence. Side effects most common is GI intolerance, which is nausea, abdominal discomfort, bloating, and diarrhea. Symptoms tend to improve with continued use of the medicine, and it's temporary. It's better tolerated when taken with food, which means right after the meal. Metformin is contraindicated in patients with impaired renal function, cirrhosis, hepatitis, alcoholism, cardiopulmonary insufficiency. And the most serious risk for metformin is lactic acidosis, but the incidence is extremely low in pediatric patients. The other risk factor, it may lead to poor absorption of vitamin B12 and folic acid, so patients should be provided with daily multivitamins, and it should be withheld before radiographic studies that required administration of iodine contrast dye because of the potential of renal deterioration. So the recommended dose is to start with 500 milligram daily, increasing by 500 milligram every 1 to 2 weeks, up to 2,000 milligram daily in divided dose, twice a day. And generally, higher than 2,000 milligram daily will not provide additional therapeutic benefit. And that's the the medicine, the oral medicine for diabetes that we use in adults. The insulin, the Metformin is the only one that's FDA approved for children. I'm not going to go through them. Now I'll talk about comorbidities. Hypertension, which is a significant comorbidity associated with endothelial dysfunction, vessel stiffness, and increased risk of future cardiovascular disease and chronic kidney disease. It's present in 36% of children with type 2 diabetes within 1.3 years of diagnosis. And there was 65% of children enrolled in SEARCH study. They had hypertension at the time of diagnosis. It should be measured with appropriate sized cuff, monitored at every clinic visit, plotted against normal for age, gender, and height. Treatment of blood pressure, if the patient have or at the 95th percentile, at least for 3 occasions, we'll start with weight loss, limitation of dietary salt, and increased activity. Failure of this intervention, we can use ACE inhibitor, is the preferred drug of choice for blood pressure. And there is, if the ACE inhibitor failed, there's other agent has been used in pediatric, like beta blocker and calcium channel blockers and diuretics. And renal evaluation is always recommended. Dyslipidemia. SEARCH study found that 65% of patients, that study was done in total of 2,000, almost 2,000 children with type 2 diabetes. So 60 to 65 have hypertriglyceridemia, 73% had low HDL. So all pediatric patients with type 2 diabetes should have baseline lipid screening at initial visit. It should be done after initial glycemic control has been established. And include fasting lipid profile with follow-up every 2 years based on the findings. Like if it's normal, it should be follow-up every 2 years. The lipid targets are LDL less than 100, HDL more than 35, triglyceride less than 150. Retinopathy, it's present earlier in children than in adults. There was a Japanese study documented early development of retinopathy in young adults. Some of them had retinopathy even before the time of diagnosis of diabetes. So this study includes about 1,000 patients diagnosed with type 2 diabetes before 30 years of age, and reported about presence of retinopathy in 9.3% of these children at the first clinic visit. 12.7% have proliferative retinopathy before 35 years of age, and 2.3% of these children were blind by mean age of 32. So all patients with type 2 diabetes should have dilated comprehensive eye examination shortly after diagnosis. And examination should be done annually. Depending on the result, may be done less frequent if it's normal, and for sure more frequent if there's any abnormal results. And any evidence of macular edema, non-proliferative or proliferative diabetic retinopathy should be referred to the ophthalmologist. Now, macroalbumin urea, which is a marker of vascular inflammation and sign of early nephropathy, It's associated with cardiovascular risk in adults and present at time of diagnosis in children with type 2 diabetes. Children with type 2 diabetes have higher rates of microalbumin urea than children with type 1 diabetes. So screening for microalbumin urea should be begin at the time of the diagnosis as well, and should be repeated annually. The recommended test is microalbumin to creatinine ratio. Treatment is preferred with ACE inhibitor for patients who have microalbumin urea in 2 urine specimens, even if blood pressure is not elevated. And after initiation of the treatment, microalbumin exertion should be monitored at every 3 to 6 months to assess both patient response to therapy and disease progression. That's it. Now, before I take questions, I'd like to thank Dr. Gangor for her help in preparing this lecture. Thank you. No questions?
Some comments. First of all, I want to thank Ahmen for this very nice outline of type 2 diabetes. And this has lots of implications towards general pediatrics practice. You know, our graduating residents now will go out in the field, they will start their own clinics. Due to the increasing rates of pediatric obesity and impaired glucose tolerance or pre-diabetes and type 2 diabetes, you may be the first-line physician seeing these patients, and sometimes in the paucity of endocrinologists, you may be the primary caregiver. So I think it is always a good idea to increase the knowledge and experience with this kind of disorder. Couple of points I want to address. I think the issues about comorbidities are very important. This can present insidiously and it can be present at a very early stage, even at the diagnosis of type 2 diabetes, so we have to remember to screen early. Blood pressure measurements are of utmost importance, and number one, we have to measure them right. We have to use the right size cuff, and when in doubt, we have to repeat those. Ahmen said that there is a hyperbolic relationship between insulin secretion and insulin sensitivity, and because of that, in type 2 diabetes, there are two main components in the pathophysiology: increased insulin secretion, increased insulin resistance. And at the initial presentation and or during stages of the disease, you may come across with variable changes to that balance between secretion of insulin and insulin sensitivity. And that will reflect to the presentation of your patient, and also it will help you guide your treatment. For example, Ahmen said some patients would present just like type 1 diabetes, ketosis, ketoacidosis, very high blood sugars. Then there is no doubt we have to start with insulin. But later on, insulin resistance, glucotoxicity may resolve, and by that time we will have the antibody levels, the GAD, ICA, and insulin antibodies, which we do a very good job of routinely obtaining with our residents. In terms of, you all do a great job making sure all those tests are done. So when those results come and when the patient comes back to clinic, we are able to make that judgment. Also important to remember, during the course of the disease, let's say you have a patient, he or she is well controlled with metformin and lifestyle modification, but then there's an intervening infection, fever and some, let's say, some infection. I always advise them to check blood sugars more frequently during those phases, because insulin resistance and insulin secretory defect may increase, and you may need to intervene with insulin therapy. It may be just a short term, but please keep in mind that type 2 diabetes in kids is a very heterogeneous condition. Thank you very much.
Thank
you. A number of years ago, I heard that maybe the tendency towards diabetes may have some sort of an adaptive role in chronic starvation. If you look at the Indians around Phoenix and so forth, when they first came in, they looked like skinny, skinny, skinny beside tribesmen. And by the time I got there, any adult under 250 pounds was skinny, and they had very high incidences of glucose tolerance and so forth. And I was wondering if there's ever been anything more worked up on that.
What I also recall from the literature is also Dr. Barter from England. He was following a group of patients. So in England, the healthcare system was such that when you are born in a town, you grow there, and all of your healthcare is provided from the same hospital. So they were able to look at the population, the adult population, and they were able to review the birth records and the records to childhood. And they noted that the ones who were coming to doctors with metabolic syndrome, hypertension, dyslipidemia, glucose regulation problems as adults, of course that also includes overweight, obesity. When they looked at the birth records, most of those were SGA or IUGR, so there were links to the intrauterine environment and exposure to diabetes in utero. Most of that data comes from the American Indians too. But there have been different reports showing effect of maternal diabetes, also poor growth in utero, but large for gestational age also links to future. So the U-curve, that sort of data comes from the American Indians.
Yeah, I guess what I'm asking is there any evidence that maybe having the propensity to type 2 diabetes may have a, why is it so common in some populations? Is there some sort of a protective effect that was proposed since these people were trying to scrounge livings in the deserts, living off of cacti, etc.? Was there some protective effect of having this tendency? Just like with sickle cell disease and malaria.
Right. That's a very good question. I don't know anybody has proven anything, but I think because of the multifactorial etiology, changing lifestyle, genetic influences, and a combination of everything else.
What age can we start metformin at?
Officially, FDA has approved it for ages 10 and above. However, in my experience, and also when I go to meetings discussing with other colleagues, I know of patients started as young as 6 years of age. Of course, good monitorization for adverse effects. And also, Ahmed pointed that we started with 1 dose a day. Usually, it is better tolerated if you give it after dinner because it causes GI adverse effects. The child will go to sleep and not feel those very much. So.
You do anything.